Caulfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things ONG. Today, we're talking about endometrial hyperplasia, and to do that, we're going to take you to the place we see these cases the most, the gynecology clinic. Today, you're seeing Tiana. Tiana is a 30-year-old lady who initially presented with irregular menstrual bleeding and an ultrasound demonstrating a suspected endometrial polyp. You booked her for a hysteroscopy, D&C, and polypectomy, which she had last week. She's come in to see you for her result, and lo and behold, it's a benign polyp. Just kidding. It's obviously endometrial hyperplasia. Otherwise, what's the point of the case? So, what exactly is endometrial hyperplasia?
Endometrial hyperplasia is technically defined as an irregular proliferation of the endometrial glands with an increase in the gland to stroma ratio. Now, that is a bit of a mouthful, but is basically the histopathological definition and one that likes to pop up in exams. Put simply, it's an overgrowth of the lining of the womb. The reason we care about endometrial hyperplasia is because it's considered to be a precursor to endometrial cancer. If endometrial hyperplasia is left untreated, it can progress to endometrial cancer, and while this timeframe is usually over 5 to 20 years, it can be as early as 1 year, so it's important that endometrial hyperplasia is detected and treated.
So, how would we normally detect endometrial hyperplasia?
Endometrial hyperplasia is typically diagnosed on endometrial biopsy, and this could be through either Purpell sampling or with a hysteroscopy D&C. Sometimes endometrial hyperplasia can be focal and found in polyps, which is one of the reasons why we always send our endometrial polyps for histopathology. Women might have endometrial sampling for a number of reasons, including abnormal uterine bleeding, postmenopausal bleeding, an incidentally thickened endometrium, or a suspected polyp on ultrasound scan. Sometimes endometrial hyperplasia might be suspected because of atypical cervical screening tests demonstrating atypical glandular cells or atypical endometrial cells.
So how does endometrial hyperplasia happen?
Endometrial hyperplasia is typically caused by excessive estrogen. In the normal menstrual cycle, estrogen is produced by growing follicles. Rising estrogen triggers the LH surge, which causes ovulation, and the developing corpus luteum produces progesterone for the luteal phase of the cycle. Now, this progesterone is usually enough to counter the effects of estrogen on the endometrium and prevent endometrial hyperplasia. When estrogen is unopposed, meaning there is not enough progesterone to counteract the estrogen, it's basically allowed to run wild and trigger all of those endometrial cells to just keep growing. Essentially, estrogen binds to receptors in the nuclei of endometrial cells, causing them to proliferate.
So why would there be too much estrogen or unopposed estrogen?
Well, unopposed estrogen can occur in a number of situations. The most obvious cause would be the administration of exogenous estrogen. Now, we typically see this if a woman with a uterus has been put on estrogen-only menopausal hormonal therapy. Menopausal women with a uterus absolutely need to be given progesterone in conjunction with estrogen in order to prevent endometrial hyperplasia or worse, endometrial cancer. Now, this doesn't apply to topical vaginal estrogens like Ovestin or Vagifem. These estrogens do not carry the same risk of endometrial hyperplasia as oral or transdermal preparations. Another example of exogenous estrogen would be through the use of tamoxifen. Tamoxifen is a selective estrogen receptor modulator that is commonly used in the treatment of estrogen receptor-positive breast cancer. While it has anti-estrogenic effects in breast tissue, it can have estrogen-like effects in other tissues like the uterus. Tamoxifen binds to the estrogen receptors in endometrial tissue, stimulating cell proliferation and predisposing to endometrial hyperplasia.
The next most obvious cause would be anovulation. Women in the perimenopause or those with polycystic ovarian syndrome, for example, will often have anovulatory cycles. Without ovulation, the corpus luteum does not form and therefore progesterone is not released. This results in the uterus being exposed to unopposed estrogen and endometrial hyperplasia. In contrast, women with anovulation due to central causes like hypothalamic hypogonadism are not at increased risk of endometrial hyperplasia because they are also not producing estrogen.
Obesity is another common cause of endometrial hyperplasia. Adipose tissue contains an enzyme called aromatase, which converts androgens to estrogens. The more adipose tissue a person has, the more aromatase activity there is, leading to a higher estrogen production. Obesity is also associated with insulin resistance. Insulin resistance can lead to increased insulin production by the pancreas. High insulin levels can stimulate ovarian androgen production and inhibit hepatic sex hormone binding globulin production, so decreased SHBG. Decreased SHBG levels can result in increased bioavailability of free estradiol, further contributing to higher estrogen levels. For this reason, diabetes is also considered to be a risk factor for endometrial hyperplasia.
The more years of menstruation you have, the more estrogen you're exposed to. And so women with early menarche before age 12 and late menopause after age 55 are also at increased risk. Nulliparity is also a risk factor since pregnancy is a high progesterone state and is actually somewhat protective.
Estrogen-secreting tumours are another rare but possible cause of endometrial hyperplasia. The most well-known estrogen-secreting tumour would be the ovarian granulosa cell tumour. These tumours arise from the granulosa cells of the ovary, which normally produce estrogen to support egg development. Thecomas are another type of ovarian tumour that can produce estrogen. And adrenocortical carcinomas might also be responsible for excessive estrogen production.
And finally, genetic conditions such as Lynch syndrome and Cowden syndrome are also associated with an increased risk of endometrial hyperplasia. A family history of endometrial, ovarian, breast, or colon cancer might also increase the risk. Obviously, age is another risk factor.
Okay, so endometrial hyperplasia is an overgrowth of the endometrium characterized by an increase in the gland-to-stroma ratio. It is caused by exposure to excessive or unopposed estrogen and is considered to be a precursor to endometrial cancer. Risk factors for endometrial hyperplasia include age, early menarche under 12, late menopause over 55 and nulliparity, obesity, diabetes, anovulation, estrogen-secreting tumors, unopposed estrogen replacement therapy or tamoxifen use, and genetic conditions like Lynch or Cowden syndrome. So let's get back to Tiana. What does the diagnosis of endometrial hyperplasia mean for Tiana?
Well, it really depends on whether Tiana has endometrial hyperplasia without atypia or endometrial hyperplasia with atypia. Both conditions are characterized by overgrowth of the endometrium. However, atypical hyperplasia contains cells with abnormal features. Features of cellular atypia include enlarged nuclei, prominent nucleoli, loss of polarity, and mitotic figures. Atypical cells have a higher risk of progression to endometrial cancer.
Wait, what happened to the old definitions of endometrial hyperplasia? Didn't we used to have 4 categories? Simple hyperplasia without atypia, simple hyperplasia with atypia, complex hyperplasia without atypia, and complex hyperplasia with atypia?
Yes, we did, and thank God we've changed that. That was always annoying to remember. The old categorization system was established by the World Health Organization in 1994 and divided endometrial hyperplasia into simple hyperplasia with or without atypia and complex hyperplasia with or without atypia. There were 4 different management strategies, one for each type of hyperplasia. In 2014, the World Health Organization revised that category to the definitions we use today, hyperplasia without atypia and atypical hyperplasia. The reason this guideline changed was because various studies indicated poor reproducibility of individual case classification. As a result, there were too many hysterectomies being performed with hyperplasia without atypia and too many patients with atypical hyperplasia being treated with progestins alone. The new World Health Organization diagnostic criteria allows for better definitions and management strategies that correlate with the risk of endometrial cancer.
Okay, so we look a little bit closer at Tiana's histopathology report. It clearly reads endometrial hyperplasia without cytological atypia. What do we do now?
The first thing we do is explain the diagnosis to Tiana. As we've mentioned before, endometrial hyperplasia is basically an overgrowth of the lining of the womb that is typically due to exposure to excess or unopposed estrogen. The reason we care about endometrial hyperplasia is because of the risk of progression to endometrial cancer. Now, endometrial hyperplasia actually has a pretty low rate of progression to cancer of about 5% over 20 years. But still, it's higher than the baseline rate, and so we would want to do something about it. As with most things in medicine, our management options include expectant, medical, and surgical management.
Expectant management with observation is typically not recommended for women with endometrial hyperplasia without atypia. If we were to do nothing, about 80% of endometrial hyperplasia cases would resolve, 19% would persist or progress to atypical hyperplasia, and 1% would progress to endometrial cancer. Now, keep in mind, the study that gave us this data only looked at about 100 patients over a short period of time, like 1 to 2 years. If the patient is adamant on this approach, and actually any approach really, then we would recommend to identify and address reversible risk factors. These would include exogenous estrogen use, anovulation, and obesity.
Medical management for endometrial hyperplasia without atypia is typically with progesterone. Progesterone has been shown to increase the regression rate from 80% with observation alone to up to 96%. So for this reason, we typically recommend medical management over observation. There are two options for taking progesterone, the Mirena or continuous oral progestins. The Mirena is the first-line option because it has a higher regression rate, a more favourable bleeding profile, and fewer side effects. The Mirena is also associated with lower relapse rates, with one cohort study showing a relapse rate of 13% over 5 years with the Mirena versus 28% with oral progestins. If the Mirena is used, it should be encouraged to be used for at least 6 months and up to 5 years in order to reduce the risk of relapse. Although the Mirena is approved for 8 years for contraception, the daily dose of levonorgestrel drops from 20 micrograms a day to about 10 micrograms a day at 5 years, and so replacement is advised. Lower dose IUDs, like the Carla, have not yet been studied in patients with endometrial hyperplasia, and so cannot be recommended for this indication.
For those who don't want the Mirena or can't tolerate it, medroxyprogesterone or norethindrone can also be used. The dose of medroxyprogesterone is 10 to 20 milligrams per day, and norethindrone is 10 to 15 milligrams per day. And the medication should be continued for 6 months. A continuous regime is preferred to cyclical regimes. Cyclical progestins are much less effective and therefore not recommended. It's important to keep in mind that some patients will experience bothersome progestin side effects like irregular vaginal bleeding, bloating, irritability, depression, or headaches, which may require a dose adjustment or switch to a different progestin formulation. Side effects are more likely with oral progestins, and so the Mirena is usually preferred since it acts locally with minimal systemic absorption and less risk of side effects. Oral progestins are also not sufficient to be used as a contraceptive, so this needs to be kept in mind if someone is premenopausal.
So how do progestins work?
So, progestins work by activating progesterone receptors, which results in stromal decidualization and subsequent thinning of the endometrium. Progestin exposure also activates hydroxylase enzymes to convert estradiol to its less active metabolite, estrogen. By these mechanisms, progestins can reverse endometrial hyperplasia.
Did you know that you could also use the combined oral contraceptive pill to treat endometrial hyperplasia? Patients are usually treated with continuous dosing. Typically, the COCP has not been studied for treatment of endometrial hyperplasia. However, the dose of progestin is, in theory, enough to reverse the majority of the cases of endometrial hyperplasia without atypia. In addition, the COCP are associated with a lower risk of endometrial cancer and can also have the benefit of providing contraception. Obviously, you would want to avoid the COCP in postmenopausal women since there is no need for contraception and no benefit to these women from the added estrogen. Whilst this is a possibility, progestins like the Mirena, medroxyprogesterone, and norethindrone are still preferred and supported in most guidelines.
What about other progestins like the Depo-Provera or Implanon?
Unfortunately, these preparations have not been well studied for the treatment of endometrial hyperplasia and so are not typically recommended.
All right, let's talk about surgical management options. Obviously, this would need to be a hysterectomy.
Yeah, so hysterectomy is a definitive treatment for endometrial hyperplasia. If you are considering hysterectomy, it's important that you try to exclude coexisting endometrial carcinoma as much as possible. This means that patients who have had endometrial hyperplasia detected on Papel sampling should undergo a HD&C to exclude endometrial cancer before having a hysterectomy. The reasoning for this is because if endometrial cancer is detected, patients should undergo full staging and have their procedure performed by a gynecology oncologist rather than a general gynecologist. If premenopausal patients with endometrial hyperplasia choose a hysterectomy, they should have a hysterectomy with bilateral salpingectomy and ovarian conservation. Salpingectomy provides protection against ovarian, fallopian tube, and peritoneal carcinomas. Postmenopausal patients should be recommended to have a total hysterectomy and bilateral salpingo-oophorectomy, although we should note that medical management is very effective and so we don't typically recommend a hysterectomy for the treatment of endometrial hyperplasia.
Okay, so our treatment options for endometrial hyperplasia include observation with identification and management of reversible risk factors like anovulation, obesity, and exogenous estrogen exposure, the Mirena or continuous oral progestins such as medroxyprogesterone acetate or norethistérone, or surgical management with a total hysterectomy and a bilateral salpingo-oophorectomy if postmenopausal, or a total hysterectomy and a bilateral salpingectomy if premenopausal. Tiana considers her options. She would like to preserve her uterus as she would like to have a child one day, and so she decides that a Mirena would be the best option for her. So we go ahead and insert a Mirena for Tiana. What kind of follow-up does she need to make sure the Mirena has worked?
Well, as I said before, treatment with the Mirena is 96% effective in reversing endometrial hyperplasia. Now, that's not 100%, so that means we need to do some kind of follow-up to check for progression, persistence, or progression to atypical hyperplasia or endometrial cancer. This is typically done with endometrial sampling. The median time for regression on progesterone therapy is 3 to 9 months. And so for patients with endometrial hyperplasia without atypia, we typically perform an endometrial biopsy every 6 months. This is fine to be done with a Propel with a Mirena left in situ. If office biopsy is not tolerated or endometrial hyperplasia is persistent on a Propel sample, then hysteroscopy D&C is recommended to exclude atypical hyperplasia or endometrial cancer. Focal lesions might be missed with Propel sampling.
We usually aim for 2 endometrial biopsies 6 months apart that show normal endometrium. If the patient no longer has risk factors, then she does not require further sampling. However, if the patient continues to have risk factors for endometrial cancer, such as a BMI over 35 or those treated with oral progestins, then annual sampling is recommended indefinitely. We usually recommend leaving the Mirena in for at least 5 years to reduce the risk of relapse. If there is persistence of endometrial hyperplasia on 2 samples 6 months apart, or progression to atypical hyperplasia, then hysterectomy is typically recommended since there is a 23% chance of endometrial cancer in these patients.
Okay, so for Tiana goes on a weight loss program to reduce her BMI and risk of endometrial cancer. She has a Mirena inserted and undergoes an office biopsy at 6 months, which shows persistent endometrial hyperplasia without atypia. Is there anything we could do differently now?
Well, given the Propel has shown persistent hyperplasia, we really need to arrange for a formal hysteroscopy D&C. This is to exclude atypical endometrial hyperplasia or cancer. If this also demonstrates endometrial hyperplasia, then our options would be to continue with the Mirena and repeat the biopsy in 6 months, or to increase the dose of progestin. The Green Top guidelines don't suggest this, however, UpToDate states that you can reasonably add an oral progestin to the Mirena to increase the chance of regression. If the patient was already on progestin, then you could also consider a dose increase or switching to a more potent progesterone, or adding a Mirena.
Okay, so we decide to add an oral progestin to the Mirena to increase Tiana's chances of regression. Since Tiana is young and nulliparous, we want to do everything we can to prevent her from needing a hysterectomy. Unfortunately, at her second 6-month Propel, she again has persistent endometrial hyperplasia without atypia. You arrange another hysteroscopy D&C, but this time the result shows atypical hyperplasia. What do we do now?
So now we are dealing with progression of endometrial hyperplasia to atypical hyperplasia. Remember, atypical hyperplasia is again a proliferation of the endometrial glands, but this time the cells have an atypical appearance. Atypical hyperplasia has a much higher risk of progression to endometrial cancer, and so our management is slightly different. We said before that the risk of endometrial hyperplasia progressing to endometrial cancer is about 5% over 20 years. With atypical hyperplasia, that risk is about 20 to 40%, and endometrial carcinoma tends to occur a lot sooner. 2 separate studies have demonstrated that in patients with untreated atypical hyperplasia, about 20 to 40% will progress to endometrial cancer within 5 years. A more recent systematic review and meta-analysis show that the rate of progression of atypical hyperplasia to endometrial cancer is about 8% per year. Even when detected on HD&C, there is a 43% chance that patients with atypical hyperplasia on biopsy might already have endometrial carcinoma.
Okay, the stats I like to remember that women with atypical endometrial hyperplasia have a 20 to 40% risk of progression to endometrial cancer, a 43% chance of already having endometrial cancer, a 4% risk of coexisting ovarian cancer, a 2% risk of progression to higher than stage 1 endometrial cancer, and a 0.5 risk of metastatic disease and death.
So you can see that atypical hyperplasia carries a lot more risk than endometrial hyperplasia without atypia. Because of this, observation is absolutely not recommended. The spontaneous regression rate of atypical hyperplasia with observation alone is only about 30%, and you can compare this to endometrial hyperplasia without atypia, where the spontaneous regression rate with observation alone is about 80%.
So is progesterone first-line management again?
Actually, no. Because of the high risk of concurrent endometrial cancer, the first-line management for atypical hyperplasia would be a total hysterectomy and bilateral salpingo-oophorectomy. If the patient is premenopausal, the recommendation would be a total hysterectomy and bilateral salpingectomy. This can be done by a general gynecologist, but some facilities do refer these patients to gynecology oncology.
If there's such a high chance of the patient already having endometrial carcinoma, shouldn't we be referring to GONC so they can do a frozen section at the time of hysterectomy?
There's actually no benefit of an intraoperative frozen section for atypical hyperplasia. This is because in about 61% of patients who have a frozen section, the frozen section histology and final histology actually don't match. For those of you who don't know what a frozen section is, it's basically where you do the hysterectomy and send it to the lab immediately. The pathologist does the histopathology while you continue to operate and phones the theatre with the result. If there was a cancer, then the gynae-oncologist could decide whether to proceed with further surgery, like lymph nodes for example, or whether the hysterectomy is enough. Another important reason why frozen section doesn't matter in patients with atypical hyperplasia is because even if endometrial carcinoma is present, it is almost always early stage with a low risk of lymphovascular disease, and so lymphadenectomy is almost never required.
Okay, but Tiana wants to have a baby. She really doesn't want to have a hysterectomy. Is there any other treatment options that don't involve removing her uterus?
Although hysterectomy is the gold standard of management for atypical hyperplasia, it's obviously not a suitable for management plan for someone like Tiana, who wants to preserve her fertility. In these cases, progesterone can be used until a hysterectomy becomes acceptable to the patient. In young premenopausal women with atypical hyperplasia who do not want to have a hysterectomy, we usually recommend referral to gynae-oncology. Tiana would be recommended to have staging investigations, including CA125, a transvaginal ultrasound, and an MRI. The point of these would be to rule out invasive endometrial cancer and to exclude a coexisting ovarian cancer. A GONC multidisciplinary team would occur, usually with an independent review of the histopathology, and a management plan would be made for treatment and surveillance.
Typically, the Mirena would be recommended as first-line medical management, with regression rates again of about 90%. Again, oral progestins can be used, however their efficacy is significantly less at about 69% and side effects are more. The combined contraceptive pill is absolutely not recommended for the treatment of atypical hyperplasia. Surveillance biopsies are required every 3 months until 2 in a row are negative. Surveillance can then be stepped down to every 6 to 12 months until a hysterectomy is performed. If fertility-sparing therapy fails to induce regression in 12 months, or there is evidence of relapse or progression to cancer, women should be strongly recommended to undergo hysterectomy.
Women wanting to pursue fertility should also be recommended to see a fertility specialist. We typically recommend at least one surveillance biopsy demonstrating normal endometrium before attempting to conceive, because this leads to a high implantation rate and more likely a successful pregnancy. Progesterone should be discontinued when a woman is trying to conceive because some of these medications may prevent ovulation and are not recommended during pregnancy. Assisted reproductive therapy can also result in a higher live birth rate, faster onset to pregnancy, which means less time off progesterone, and may prevent relapse compared to women who attempt natural conception. In general, the live birth rate after atypical hyperplasia is about 26%, the relapse rate is 26%, and there is an 85% progression rate. Completion hysterectomy should be considered a completion of childbearing to prevent progression to endometrial cancer.
Okay, so atypical hyperplasia has a 20 to 40% risk of progression to endometrial cancer, a 43% chance of concurrent endometrial cancer, a 4% chance of concurrent ovarian cancer, 2% chance of progression to greater than 1 stage endometrial cancer, and a 0.5% chance of metastatic disease and death. With observation alone, there is a 30% regression rate.
First-line management is a total laparoscopic hysterectomy, bilateral salpingo oophorectomy for postmenopausal patients, and a TLH bilateral salpingectomy for premenopausal patients. In those desiring fertility or in whom hysterectomy is unacceptable, the best management is a Mirena or, less ideally, oral progesterone.
Surveillance includes 3 monthly endometrial sampling until 2 consecutive are negative, and then 6 to 12 monthly until hysterectomy can be performed. Women desiring fertility should ideally wait for regression on one biopsy in order to improve fertility and be referred for ART to minimise time off progesterone.
Completion hysterectomy should be considered at completion of childbearing to prevent progression to endometrial cancer.
Okay, so before we wrap up, are there any other treatment options that have been studied for endometrial hyperplasia?
There have been some very small studies which have used other medications or surgical options for the treatment of endometrial hyperplasia. Ovulation induction with clomiphene or letrozole has been described. The idea is that ovulation induction results in formation of a corpus luteum, which increases the production of endogenous progesterone, causing resolution of endometrial hyperplasia. Metformin has been shown to have both anti-proliferative effects and to reduce insulin resistance, which may play a role in the development of endometrial cancer in patients with obesity. And GnRH agonists have also been used in conjunction with a Mirena for the treatment of endometrial hyperplasia with atypia or early-stage endometrial carcinoma. Unfortunately, most of these studies have been small, and further research with larger randomized controlled trials are needed before any of these options can be recommended.
Regarding investigational surgical options, hysteroscopic resection of endometrial hyperplasia has been reported to be effective in 68 to 73% of patients, but the long-term consequences are uncertain. Bariatric surgery also shows promise, with one study showing that women who underwent bariatric surgery had lower rates of cancer compared to those who did not undergo bariatric surgery. It's important to note that endometrial ablation is not recommended for patients with endometrial hyperplasia. As we've just mentioned, follow-up with repeat endometrial sampling is important to check for resolution, persistence, or progression to endometrial cancer. And if you burn the lining of the uterus, then it can be impossible to take a good biopsy. So you might miss a diagnosis of endometrial cancer.
So what do we do if a patient has an endometrial ablation without any previous sampling and the curettings taken on the day of the ablation come back later showing endometrial hyperplasia?
Well, since we can't perform follow-up sampling for these patients, they should really be recommended to have a hysterectomy. This is why it's so important to take an endometrial biopsy before booking someone for an endometrial ablation. They're clearly trying the ablation because they don't want a hysterectomy. So if you deny them the opportunity to be managed conservatively, then that's really unfair to the patient.
Now, we know you love a summary, so in case you've been zoning out for the first half of the episode, listen up. Here are the key points you need to know. Endometrial hyperplasia is irregular proliferation of the endometrial glands with an increase to the gland to stroma ratio. It's a precursor to endometrial cancer and is caused by exposure to unopposed estrogen, which encourages endometrial cells to grow.
There are 2 main types of endometrial hyperplasia: endometrial hyperplasia without atypia and atypical hyperplasia. The diagnosis is based on the presence or absence of cellular atypia, which might include prominent nucleoli, enlarged nuclei, loss of polarity, and mitotic figures.
The first step in management of either type of endometrial hyperplasia is to identify and reverse risk factors. The risk factors for endometrial hyperplasia are similar to those for endometrial cancer and include age, early menarche under 12, late menopause over 55 and nulliparity, obesity, diabetes, anovulation, estrogen-secreting ovarian tumours, unopposed estrogen replacement therapy or tamoxifen use, and genetic conditions like Lynch or Cowden syndrome. Addressing these factors is essential in managing preventing progression of endometrial hyperplasia, and this means trying to optimize BMI through diet and exercise, cessation of unopposed estrogen HRT, and optimizing medical conditions such as diabetes.
Endometrial hyperplasia without atypia has a low risk, less than 5% over 20 years of progressing to cancer, and often regresses spontaneously. 80% will resolve, 20% will persist or progress to atypical hyperplasia, and 1% will turn to cancer over 1 to 2 years. Management typically includes addressing reversible risk factors like obesity and ovulation and using progesterone therapy. Some patients may opt to do nothing and just resample to assess for regression. The Mirena IUD is the first choice due to its high regression rate and is generally recommended to stay for 5 years. Second-line options include medroxyprogesterone 10 to 20 milligrams daily or norethistone 10 to 15 milligrams daily. Treatment should continue for at least 6 months. Surveillance includes 6 monthly biopsies until 2 consecutive are negative. Patients with a BMI over 35 or who were treated with oral progesterone should continue to have annual surveillance biopsies.
Atypical hyperplasia has a 20 to 40% risk of progression to endometrial cancer, a 43% chance of concurrent endometrial cancer, a 4% chance of concurrent ovarian cancer, a 2% chance of progression to greater than stage 1 endometrial cancer, and a 0.5% chance of metastatic disease and death. With observation alone, there's only a 30% regression rate.
First-line management for atypical hyperplasia is a total laparoscopic hysterectomy and bilateral salpingo oophorectomy for postmenopausal patients and a total laparoscopic hysterectomy bilateral salpingectomy for premenopausal patients. In those desiring fertility or in whom hysterectomy is unacceptable, the best management is a Mirena or less ideally oral progesterone. For these patients, surveillance includes 3 monthly endometrial sampling until 2 consecutive are negative, and then 6 to 12 monthly until hysterectomy can be performed. Completion hysterectomy should be considered at completion of childbearing to prevent progression to endometrial cancer. And women desiring fertility should ideally wait for regression on one biopsy in order to improve fertility and be referred for assisted reproductive technology to minimize time off progesterone and improve their chances of successful pregnancy. They should also have a complete workup with a gynecology oncologist, including CA125, transvaginal ultrasound, and pelvic MRI in order to exclude the coexistence of endometrial or ovarian cancer.
Thanks for listening to this week's episode of the Uterine Sound podcast. You can find our summary slides on Instagram later in the week. If you have any comments, feedback, or want to fact check us, please reach out on our email, theuterinesound@gmail.com. You can also reach us on Instagram and Facebook at The Uterine Sound or our website, www.theuterinesound.com. Thanks.